topic which we have chosen is from the module 4, and it is basically on female infertility evaluation. So I'll be dealing with this topic in two parts. So today's lecture, basically we are going to discuss when do we actually start evaluating female infertility, then what are the points which we need to cover when we talk about female infertility. So when do you call a couple that they should come for an evaluation? You should know, na? For example, if anybody is married last year in October or September, and they come into a clinic, oh, it's been 3 months, and we were trying to conceive, but we didn't. What will you tell them? You're going to tell them that your chance of conception in 1 month, even if you're planning, is just 20%. Sorry for my voice, I have little sore throat. The chance is only 20%. Okay. So a young couple who has no comorbidities at least should try for a year before they get any treatment or they get evaluated. This is for a young couple who doesn't have any morbidity. Okay. Now, this is not true for each and every patient. For example, nowadays, the biggest drawback, or you can say because of our working culture and everybody's working and we are career oriented, we marry late. So if you have a couple who's above 35 years of age, you cannot tell them to wait for 1 year. You cannot tell them. In those couple, maximum, if they don't have other comorbidities, you can maximum wait for 6 months. So that is how you have to start when we talk about evaluation. This is how you have to deal with the patients, which are the group of people who actually needs to be intervened early. Is anybody who has irregularities in periods. For example, 30-year-old lady, you have two couple. Couple one, both are 30 years of age, both husband, wife, 30, 31 years of age. Couple one, no comorbidity, normal cycle, no problem. Husband is non-smoker, non-alcoholic, no problems they have. Then you can ask them to wait for 1 year. But instead, second couple, either the husband has some history of substance abuse or any other erectile dysfunction or any other problem, or if the wife has irregularity in periods, she is a known case of PCOD, if she has history of any other comorbidities, any medical history, any drug she's taking, or any drug the husband is taking, these couple, we need to intervene early. Though they are 30 years of age, still you need to intervene early, okay? Now, when we talk about the causes of infertility, if you look at this pie chart, I hope you all can appreciate that it's not always the female who are the cause of infertility. In our Indian society, we all know, whenever we talk about infertility, every time the mother-in-law and everybody will be sending the female only for evaluation. Ki go get evaluated, and most of the time they'll be accompanied by their in-laws or their relative. Other the female will accompany that girl or a woman. When they walk into your clinic, always politely tell them that both male and female actually contribute equally to infertility. Why I'm saying that? You look at this chart, you will say that male factor I've written only 30%. I've written no. So why I'm saying both are contributing equally? Because in this group, what I have not included is the unexplained infertility. That is around 20%. Okay. So that group also needs to be evaluated. If anybody asks you in exam how much individually a male contribute, it is around 30%. If individually, if anybody asks you, but if they ask you how much a male can actually contribute, it is up to 50% if you include unexplained infertility also in that group. Now, what are the other causes if we talk about? There could be ovulatory causes, there could be endometriosis, there could be tubal factors, so many things. Unexplained infertility is a very important part, which actually we sometimes miss and we don't get any cause. It becomes difficult to manage these patients, but they totally contribute to 10% if we take individually unexplained infertility. Okay. Now, let's talk about evaluating an infertile female. We are not covering male. We are just talking about female infertility today. Okay. So, can you all see what I have mentioned over here? We need to test for ovulation. We need to test for ovarian reserve. We need to test for cervical factors. We need to look at the uterine factors, tubal patency, and peritoneal factors. In today's lecture, we will cover from ovulation to ovarian reserve to cervical factor and uterine. Tubal patency and peritoneal, it's a very long thing because in tubal patency, you need to learn how to do HSG, how to do saline infusion sonography and all those things. So we'll take it in next part. Okay. Now let's talk about ovulation. Before you go and start examining a female patient, you all know, see what we read in our basic MBBS days. I hope everybody remembers that. History and examination. That is the chunk and that is the goal which we should have. Like you have to first take thorough history. If I tell you a scenario, once I had a couple. They walked into my clinic. They were pretty okay, no comorbidity, nothing. But suddenly, when I started taking history, they said, we have no problem. We don't have any smoking. We are having intercourse regularly. That is what they told me. And when I asked the patient, okay, it's fine. When everything is fine, let me start my examination. I told the patient, please go and lie down. It took me 10 to 15 minutes to convince the lady just to lie down on the table. What is it this telling me indirectly? Though they are saying they are having intercourse regularly and all those things, this is telling me that maybe the girl, the lady, the woman is having vaginismus. She is afraid to lie down. That one simple thing gave me a lot of clue. And when I actually made the husband go away, I sat with her, and when I asked her, she told me she is very anxious when they want to have a sexual intercourse. She gets agitated. See, these hormones also do play a role. They can cause problem unknowingly. This vaginismus can easily be treated. I told the girl, okay, you can use these. These are the medications which will help you. I counseled her. I told the husband she needs more counseling sessions. She came. They got a healthy baby just by treating vaginismus. That is why when you start evaluating the patient, please start with history. Once you're done with the history, go for examination. Examination is always head to toe. Look if there is any anemia, if you find any features of jaundice, if you find any features of PCOS, any enlargement in the neck, breast examination. Per speculum and PV. Now, in today's era, I feel so sorry many a times what I'm seeing in OPDs. None of the doctors are doing PS and PV as a routine. They take the history, they write per abdomen, they write the medicine. That's all. If any prescription of yours has this, kindly review that and please ask the patient that she needs to undergo examination thoroughly. Many times patient will also refuse. It's not always a doctor. Many times patient will say, iski kya zarurat hai? You need to explain to them that this is necessary. Why this is necessary? Because first, I told you just now, I told you the case, no, that vaginismus girl. Interruption. Actually, my sore throat is not allowing me to speak only. So basically, you should start with examination and never skip this per speculum examination and PV examination. Now, if we talk about examination, I hope, see, please, I want the session to be interactive. Everybody should answer in the chat box or you can ask your queries so that I can clarify. This is about discussion. I don't want to bestow with lot of information and you don't understand anything. Okay. So when we start evaluating a female, first, if the lady has come alone, please come as a couple, call your husband also. Second, start with history. Take history about regularity of the cycle. Ask her about symptoms. We all as a gynecologist know that a normal ovulatory cycle has very important features. First, it is regular. Second, there is Mittelmarsch pain. Third, she will have the nature of the discharge, the vaginal discharge will change. First, it will be thin, watery when she is in fertile period, during before ovulation. After ovulation, it will become thick, it will be dry. All this will tell you whether she is ovulating normally or not. Just by history, you can predict. You cannot be sure, but you can predict. Second, when you want to confirm whether she is ovulating, you have various options. You can look at hormone level. You can do ultrasound. How on ultrasound do you see ovulation? Anybody of you have seen ovulation on an ultrasound? Or if you are doing a transvaginal scan, anybody here? See, on an ultrasound, what you can do is you start doing the scan of the patient every alternate day. You will see that the follicle is growing. And one certain day, day 12, 13, 14, whatever her cycle duration is, you will see that that egg is gone. The margins will become irregular. There will be ring of fire, that is corpus luteum will be formed. There will be free fluid in the pouch of Douglas. These are the ultrasound sign that ovulation has happened, and it is a definitive sign. When you do the scans, you will see it. Next, how will you confirm? Is by doing serum progesterone level. You know, progesterone hormone only comes in the second part of the cycle. So if progesterone is high, by high I mean more than 3 nanogram per ml, it tells you that ovulation has happened there. Okay. Now, these are the basic things. You have taken the history, you have confirmed the ovulation, and then you look at the tubes. For tube, what you do is routine is HSGV. I know everybody is aware of that. That is hysterosalpingography, is the test which we do to evaluate whether the two tubes are functioning or not. Now, if you have done all this, I want to show you a case. Please look carefully at a prescription. This is a prescription I just wanted to share. There's written Pooja saying, wife of Ramesh Singh, 26 year, complaining of inability to conceive. This is, I think, last year, September, OPD prescription. Next, it's written that she's married for 2 years, non-consanguineous marriage. Her last period is 20th September. Previous cycles are regular. She's nulli gravida, nothing significant in past history. Husband also non-alcoholic, non-smoker. They are normal couples. Family history is also negative. So there is just on examination, per abdomen is soft, and battery of investigations are written, medications are written, and HSG is written for advice, and patient is called next time. Do you feel is it correct? I hope after me emphasizing, you will see that this prescription is not valid. The patient has not been examined at all. There is no description about the examination. And the amount of tests which is written over here, maybe those are not indicated also. If I tell you now that AMH is not for all, most of you will be shocked and say that AMH is a routine. Why madam is saying AMH you should not do? AMH is a test, which is a very good test for ovarian reserve. I do agree. But nothing in this world is short for anything. If you actually read the guidelines, ESHRE says, and even ASRM says that you should do AMH only in ladies where there is actually problem in periods, means having some kind of AUB, or if her age is more. Routine AMH in such kind of 26-year-old girl, if the husband age is also okay, means in this such low risk group, you don't have to go and do a AMH. It's a costly test. It's around 2,000 rupees. Just an ultrasound of how, I don't know at your place how much it is, but at my place it is for 1,100 rupees, and in 1,100 rupees we do the entire cycle. That is much cheaper, and that is also telling you about the reserve by looking at antral follicle count, and you will see the ovulation also. So when you see this prescription, kindly, if such patient comes to you with such kind of prescription, and I am very sure that everybody will agree, please, you examine the patient. Okay? So how do we start? Start with history. In female, look for ovulation, ovarian reserve, uterus and the tubes. Male, basic semen analysis with 3 days of abstinence, that's all. What should not be done routinely? Can you see? This is from ASRM. No L, no I, no G, no O unless indicated. That is, no test for luteal phase like biopsy or repeated progesterone levels. You don't need. If you have seen ovulation by your eyes, you don't have to do a serum progesterone. That is just to supplement. No I means no immune mediated tests like ANA, APLA profile, thrombophilia. These are not routines. They have to be chosen specifically based on case to case. No G, that is no genetic test like karyotyping or CFTR, cystic fibrosis gene mutation. And no O, that is over investigation. Now, many places, laparoscopy, hysteroscopy, AMH, they are routine. These are not routine investigation. You have to choose these investigation depending on patient to patient basis, not for everybody, not like sabka kar dena hai. No. Now, let's start discussing these tests one by one. So, test for ovulation, we already discussed history. As I already told you, if somebody has a regular cycle, there is premenstrual symptoms, she has mitral there is regular bleeding, she is ovulating. Even on history, you can suspect an ovulation if their cycles are irregular, if she is overweight, if she has acne, if she has hirsutism, if she has galactorrhea, if she has hot flashes. These things will tell you whether the patient is having ovulation normally or not. To complement your history, even examinations. If somebody is of very high BMI, if somebody has acanthosis, if somebody has hirsutism, if the thyroid is enlarged, if there is virilization in the female, you know that there is androgen is more. So there is problem in ovulation in this girl or lady. Okay. To confirm, you have a hormone test that is known as by serum progesterone. I told you 3 nanogram per ml. And you have ultrasound to supplement. Okay. Now, see, you can do ultrasound. That is very pretty simple. If you start doing that, you will easily predict when ovulation is happening. Another very basic test, which you can, at least a patient can do, is a urine LH kit. See, for you to explain to the patient how to do a UPT, everybody knows. Similarly, you can do LH hormone also. I hope you all are very well aware that before ovulation, LH surge will happen. At home, just by urine, you put 2 drops of urine in that kit. It is 50 rupees kit like UPT kit. You will know that if the LH surge, that kit comes positive, 2 lines, LH surge has started, means she will ovulate in next 24 to 36 hours. So, always, if the patient cannot come to get progesterone, if the patient cannot come for repeat scan, she is living far off, and you want to tell her when to time the intercourse, because we know egg is only alive for 24 hours, and if they are not together in that period, though it is said that up to 7 days the sperm can fertilize if it is there in the vagina, yes, agreed, but the capability of sperm to fertilize also decreases with time, and ovum also is alive only for 24 hours. So if they try when actually ovulation is happening, their chance of conceiving increases. Therefore, if you're not doing anything and you want to keep it a minimum cycle, do one thing, start folic acid for the patient based on her cycle. Like, for example, if anybody has a 28-day cycle, she will ovulate on day 14. We all know that. So at that time, you tell her to do urine LH kit 2 to 3 days prior. Like, for example, her period came on 1st of January. She has a regular cycle. You know, around 14, 15, she will ovulate. So what you can tell the patient, from 12th night, you start doing the kit. If the kit come positive, the patient should know that she will ovulate in next 24 to 36 hours. So that is her fertile period. So for next 2 days, you tell them, after the line is 2 line are there, next 2 days is your maximum fertile period. You can conceive, your chance of conception is maximum in those 2 days. So this is the minimum method by which you can help the patient, and patient doesn't need to come back to OPD, and patient also will be very happy. By simple kit, you tell them. Okay? And it's not costly, hardly 3 kits or 4 kits they will need to buy it, and that will be 100 to 200 rupees. That's all. Okay? Now, I told you serum progesterone, if it is more than 3, this is as per Swarov's, ACOG and ASRM. But if you look at one more guideline of Australia family physician, that says more than 5. So to avoid confusion, 3 nanogram is standard by most of the guideline. So if you want to test progesterone to confirm whether the girl or woman is ovulating or not, one cycle you can do serum progesterone or day 21 or day 22. Okay? Now, how to do urinary kit monitoring? I told you 2 to 3 days before expected LH surge, you start doing the kit. If it's come positive, you know that she will ovulate. If no, she has to continue doing till it comes positive. You can also do serum levels of LH and all, but those are very tricky thing. Only one drawback with urine is that, see, for LH to come in urine, obviously it will be later as compared to serum levels. Serum levels will rise before, then gradually it will be excreted in urine and it will be seen on the kit. So urinary LH kit is not that long lasting. So if the patient doesn't do it daily, she may miss that fertile period. That is one drawback of using urinary LH kit. But if you explain to the patient that she cannot miss it, patient are very anxious. They will do it perfectly. Okay. Now, you can do endometrial biopsy also to see whether there is progesterone or not. You all know when progesterone hormone is there is secretory phase of secretory phase is there in the endometrium. But it's an invasive test. Biopsy is a painful procedure. Then the cost of biopsy also will be added. So, and the most important thing, you may disrupt the ongoing normal pregnancy. That is why when we have so many good methods, non-invasive method, why we want to do invasive? That is why nowadays nobody does endometrial biopsy just to confirm whether ovulation is happening or not. TVS is the best method because you start from day 2, you know that now the follicle is going to rupture. So you can actually predict when the patient is going to ovulate. Now, if you have confirmed ovulation, patient is ovulating and still not getting pregnant, then you have to go and do tubal evaluation. If she is not ovulating only, if you have confirmed that she is not ovulating, you have to search why is she not ovulating. Does she many things? She has a premature ovarian failure. Then you need to classify her ovulation problems, ovulatory dysfunction based on WHO classification. So WHO type 1 says that hypogonadotrophic hypogonadism. Nothing is working there. Type 2 is where hormones are normal. Type 3 is hypergonadotropic hypoestrogenism. Means the ovaries are not functioning, but the secretion of FSH and LH is okay. Last is hyperprolactinemia. These are the 4 groups by which you classify ovulatory dysfunction and you manage. Okay? See, if it is hyperprolactinemia, you are going to start kebagoline or bromocriptine. If it is PCOS, you're going to manage on that line. Like that, you have to treat. If it is hypo, then you have to start stimulating LH, FSH hormone injection of gonadotrophins you have to give. With gonadotrophin, with that pulsatility, that sequence will be maintained and patient will ovulate. Okay? Now coming to next. Ovarian reserve. Many times, though the patient is ovulating, her reserve may not be good. If reserve is not good, then also she may not have good outcome. And how do you test for reserve? See, basically, we all know ovarian reserves are decided at birth. Maximum oocyte we have at around 20 weeks. And as we age, our number of follicle in a lady decreases. That is why a lady has a particular fertile or reproductive age group, but male don't have that. Male can reproduce at any age. So we need to predict that ovarian reserve, and the tests which is available are a lot of tests. I'll show you the tests. Please see. AMH, FSH, estradiol, inhibin, AFC, volume, so many. What we actually use, we will discuss only that. Now, the two most common tests which we use is anti-Mullerian hormone and antral follicle count. If you see this beautiful diagram, what you will appreciate that AMH is secreted from small pre-antral follicles also. But in ultrasound, you can only see antral follicles which are between 2 to 10 mm. A very small thing will not be visible to our eyes. Therefore, this is one of the reason why AMH has become so popular, because it is looking at the reserve which is not visible on ultrasound also. Okay, the best predictor of ovarian reserve, if anybody asks you, is the age of the patient. Young patient, good reserve. Until unless she has a premature ovarian failure, but that's very rare. Age is the best predictor of ovarian reserve. Anybody whose ovarian reserve is declining, obviously what will happen? The feedback because of estrogen progesterone is going down. So the LH-FSH will be increasing. When FSH increases, it will cause positive increase in estradiol for some time. Then when totally the ovary becomes malfunction, ovary is not function, dysfunction is there, then finally the hormone level will decrease. So this you have to understand, that feedback inhibition of estradiol will affect the FSH level. And estradiol is not only produced in ovary, we all know that. It is produced peripherally at so many places, placenta, so many organs. Even in a fat, estriol is produced. So this is one hormone which is affected by so many things. And even many a times patients are on medication like COCs and all. Therefore, we recommend not using this test. These are the most common reason why these tests are not used. And that's why I told you we only use AMH and AFC most often as a routine. What is AFC? Antral follicle count. You will count all follicle which you see in your ovary, measuring between 2 to 10 mm, and you will take a total. For example, there were 5 AFCs in right and 4 in left ovary, so it is 9. Okay. Any antral follicle count between 10 to 20 is called as normal. If it is less than 5, then it is a poor ovarian reserve. And if it's more than 24, it is very high reserve. Means risk of OHSS or PCOS is high in these patients. Okay. The best way to count AFC is using a 3D modality. By 3D ultrasound, there is a software called as Sono AVC. Very easily it will give you. You don't have to count also. You just click on 3D. You click there. It will count and give you. There are 5 early follicles, 4 early follicles. You don't have to count also. Life has become very easy with AI. Now, if next thing, next thing is the ovarian volume. If the reserves are okay, what you normally do in a transvaginal scan, you count the number of follicle and you measure the ovarian volume. Normally, how you measure? You take the length, breadth, height into 0.52. This is how you calculate volume of a ellipse. Do that. Normal volume is around 6 cc. How I remember is 3 into 2 into 1 centimeter is ovarian dimension, and 3 2s is 6. It is 6 centimeter, 6 cubic centimeter. For uterus, how I remember, 3 into 2 into 1 inches. That's how you remember. Okay. So it's very easy if you remember like this. When you're measuring the volume, we can also look at the ovarian stromal blood flow. If the blood flow is good, you know the resistance will be less. So when the PI and the RIs are low, that is RI less than 0.6 or PI less than 1.5, means good flow is happening. That is telling you that the ovary is functioning properly. I hope you understand PI and RI. If you don't, we will take it when we are doing Doppler physics basics. Okay. But the word is explanatory. Resistance index, pulsatility index. Anywhere where resistance is high, Ri should be high. Anywhere where the blood is very, very pulsatile means that the vessel is very narrow, the pressure is high. I hope you understand now, okay? So it should be low. Next, the most and the very important thing which we do is a AMH, anti-Mullerian hormone. Anti-Mullerian hormone, as I showed you, it is also secreted by the smaller follicles. See, I showed you. Small preantral and the antral follicle also secrete AMH. Therefore, it is better than AFC. And that is why it has become so famous that everybody is doing for each and every cases. So, if we talk about AMH, see, it is not affected by the day of the cycle. It is not affected by lab to lab variations are less. You can do it any day, anytime. These are few benefits of using AMH, but I should tell you, your sample correction method affects AMH value. If you take the AMH and it's not centrifuged immediately, it is kept somewhere outside, not in the refrigerator and all, the value of AMH will be affected and it will not be accurate. That is why many patients who have very low AMH of 0.5 or 1.2 will conceive naturally and come back to you and you will not know, oh, how she conceived. You cannot say that a value of AMH which is low confirms that she is infertile. You can never say that. Many factors actually affect AMH. Medicines like COCs, smoking, obesity, metformin, vitamin D3, all these will actually affect the AMH level. So these things you have to keep in mind when we talk about AMH, okay? Why COCs? What is COCs? Combined oral contraceptives, okay? So why they affect AMH and for how long? Actually, what will happen when you are taking already estrogen and progesterone, which is there in COCs, there'll be feedback inhibition to the FSH. So brain will not produce any FSH, will not be produced by the pituitary. What will happen? The follicles will not be recruited, they will not grow. No AMH. So if you're using COC for contraception, your AMH will be low for 2 to 3 months and gradually it will pick up. Vitamin D low level also affect AMH transcription. So if transcription is not happening, no proteins will be produced. So that is why it is said that such lady, you should supplement vitamin D. Another thing which correlate with vitamin D, that in winters, the AMH value for a lady is less. There is seasonal variation. This is another reason, okay? So AMH is also affected by other hormones like androgens, which are increased in PCOS or non-classical late onset CH or androgen secreting tumors of ovaries like granulosa cell tumors. This is a very beautiful table from American Journal where can you see for AMH it's written any day there is no variability, minimal variability in the intercycle or intracycle. That is why it became very useful. But if anybody asks you, there's one simple test and single test which can tell you that reserves are very good age. Apart from age, you cannot say anything is equal or equivalent to age, nothing. That is why we use two things together. That is, we use AMH and we use AFC together. And we don't rely on one thing. So what does ASRM says about ovarian reserve? Clomiphene challenge test, these are obsolete tests. I'm not teaching you all those. So that's obsolete. AMH and AFC are the most sensitive and reliable methods. Combined reserves model do not consistently improve prediction that the patient will get pregnant. Low AMH should not be used as a marker that IVF cannot be done. It is just telling you that reserves are not that good, but still, reserve is not good. She can have natural pregnancy also. If a lady on stimulation, like you're giving drugs to increase ovulation, but still it's not ovulating, you know that the reserves are poor. You don't have to do a test to prove that. If the ovaries are not responding to gonadotropins, you know that the ovary are failing. Okay. This is what is the conclusion from the guideline of ASRM 2020. Now coming to cervical factors. See, in survey, we know cervical factor is a very important thing. What problems you can have? You can have abnormality in the cervical mucus if there is a lot of antibodies, if there is a lot of infections, if patient is on any drugs. The sperm attains the capacitation happens in the cervical vaginal region in the POD where the semen is deposited. So if there's problem, that will not happen. The sperm will not gain motility and the sperm will not reach the ovaries. If there are a lot of anti-sperm antibodies in the cervical mucus, they will kill the sperm then and there only. There may be cervical stenosis or narrowing that can be congenital, like MRKH, or due to conization or any biopsy which you have done on the cervix. There could be infections, there could be trauma from any cervical surgery. So these factors can contribute to infertility. When we talk about evaluation in infertility cervical causes, start with medical history examination, do a cervical mucus analysis. During her ovulatory phase, the cervical mucus shows a spin bucket that is very thin mucoid. It stretches when you take the mucus and stretch. It will stretch. Do the postcoital test and screen the patient for infection. Why that is important? Because if you have planned to do intrauterine insemination, you have to look at the cervix, whether it is possible or not. If it's not, you may have, if the patient doesn't have a cervix, you cannot do IUI. In those cases, IVF is the last resort. Okay? And if the cervix is damaged too much, you have to plan on cerclage. That and all you can do in the preconception period also. So cerclage, you may do it earlier only, the abdominal cerclage, and keep it there. Now, coming to postcoital test. What is postcoital? If you ask many people, they will say it's an obsolete test. Yeah, in book, it is an obsolete test. But why I'm telling you about postcoital test? Because this postcoital test gives you it's a very simple test. From the POD with tuberculin syringe, take few amount of mucus, put it in a slide and see it. See how many sperms are there. See if the sperms are moving or not. How good is the mucus. And when you're doing that, you're actually doing the PS also. And along with that, you can do the PV also. So this one simple thing, it's not going to cost tuberculin syringes of 2 or 5 rupees. Easily you can do a test and you will get so many things. If the sperms are not moving, you have to check for anti-sperm antibodies and you have to give medicines. Okay? So this, though obsolete, but can give you a lot of information. So what's the role of PCT in today's era? When we suspect anti-sperm antibodies, when we suspect cervical factors of infertility, when no other cause of infertility is found, and when we are deciding on IUI, this can be useful. Now coming to uterine factors. See, uterine factors can be many. It could be structure malformation, it could be hormonal issues. So structure, if I talk about, there could be a polyp, there could be a fibroid. So many things can be there. There could be Asherman's after any DNC patient has undergone. There could be hormonal disbalance which can lead to adenomyosis. So these factor needs to be corrected because they are decreasing the implantation rate of the embryo. Now there is one term known as AUFI, which means absolute uterine factor infertility, which means that there is no uterus. You cannot do adoption, means uterus is not there. So your option is only adoption, uterine transplantation, or surrogacy. So if they want to have their own children in such patient where there is no uterus at all, you can do uterine transplantation and give them their pregnancy. Ovaries they don't have the uterus only. If they don't want, then adoption is a simple and a easy method which they can follow. And where are we today? If we talk about in 2014, world first children was born after uterus transplantation in India, I think 3 till now. First was in 2018 and it was in Pune. So it's not a dream or it's not something which is not happening, not a common thing to be seen. But yes, India also is there in this race and India has successfully done a womb transplant. A girl was transplanted uterus of her mother and then she gave birth to a live child in 2018 in Pune. So this was all about till uterine factors we have covered. Now we have are left with tubal and peritoneal factors. And other tubal factor actually is a very big lecture where we have to talk about all the comorbidities of the tubes. So that we have to take in next lecture. We cannot complete it today itself. And if anybody wants to have a handbook of ultrasound in OBGYN, this is my book and this is the email ID where you can inquire for regarding this. Okay. Now, thank you very much for your patient listening. Any